Our third subcommittee and focus area is aging and end-of-life care. And this group has a challenge in the spectrum and just the range of topics that they focus on within their group. So one of their areas of focus is the relative newness of the population of aging people with disabilities. So we have heard from individuals who have said, I want or need this healthcare program or treatment as an aging individual, but I've been told that I'm not a fit for it because I also have a disability. So it's this kind of intersection of geriatric or aging healthcare settings that are really unfamiliar with accommodating people with disabilities, which can seem a little ironic, but apparently is a reality that we hear of often. So there's just this lack of knowledge of disability issues among providers who specialize in geriatric issues. Another concern that we have, which is separate from age really, is the concern that people with disabilities are recommended for hospice care much sooner than their non-disabled peers. So the idea of medical futility, which means when the healthcare system decides that there's really nothing more we can do, or if we did more, it would cause you more harm than good, and we wouldn't achieve any gains in your length of life and or quality of life. So there's concerns and research that supports the concern that providers often kind of wave that white flag of medical futility sooner if they know that a person has a disability than they do if not. And that can even come up. There's been studies where just vignettes have described patients, and just the mere mention of a disability has resulted in earlier kind of termination of looking at options for care than if an individual doesn't have a disability. So again, that difference in value of life is a concern. There's also the concern for this group in terms of what happens once an individual is in hospice care. So there are some really interesting and complicated policies related to hospice in terms of whether and when an individual can be in hospice care and receive certain interventions, such as like feeds. So some things that may have already been part of that person's everyday life and reality are now classified as medical interventions that would prolong life. And so sometimes there can be this collision of needs and wants for an individual and their family who are already facing the challenging reality of end-of-life care, but they really feel like they don't have the same fluidity or kind of flexibility and choices that others who are at the same crossroads do. So an example of that, in addition to the feeding tube example, is that we've heard reports of there's a commonly held value in our society that many people prefer in their last days of life to be at home and not in a hospital setting. But we've heard that that request has been denied for people with disabilities because the idea is they're already medically complex and the care can't be managed at home. And so there have been some stories retrospectively told from those individuals, but more so from their family members who have advocated and said, I wanted the same thing. We wanted the same thing as our non-disabled parent had, but were told that they would not be discharged from the hospital, could not receive hospice care at home because of their pre-existing disability. So you can see that this group has a wide spectrum of issues to address that aren't necessarily all tied to aging, but also aren't necessarily all tied to end-of-life care. A really fascinating point of discussion that has come up in this group has been how early, it seems, seemingly compared to other population, aging issues can appear in certain populations of people with disabilities. So aging issues for some people with disabilities may start at 35 or 40. So again, you can't always just separate out what's disability related and what's not, but what we're trying to identify is what inequitable treatment is caused by or made worse by bias. So this group is also very active in lots of different directions. Our fourth group is related to mental health and also the topic of suicidality and prevention of suicide. So this group focuses on everything from screening of suicide, which we realize is not a very accessible process and it isn't very inclusive, but also access in general to mental health services. And once you get in the door to a therapist, trying to find a therapist that also doesn't implicitly or explicitly interweave ableism in treatment is a challenge as well. Um, so one of the ways that we have addressed this is through the development of a suicide prevention curriculum for youth with disabilities. So this one is called Undoing Ableism, and it was actually just finished but hasn't been rolled out yet. So we're waiting for that in partnership with a Center for Independent Living in Maryland. But we do hope that this will be available to share after it's implemented. But the unique thing about this curriculum is that it addresses stigmatization and ableism with the youth themselves. So in addition to learning about mental health and depression and signs of suicide, it's also for many youth the first time they've had a chance to learn about ableism and stigma and how that may influence their mental health. So it's a group format that leverages kind of that peer support in developing one's disability identity while also recognizing challenges of having a disability in a world that is not built for us in some ways or in many ways. So this is based also on evidence of suicide prevention programs that have been effective for other marginalized groups as well. So we're excited to share that more when it's out, and we know this is a missing piece that one of many. So we know that there's also bias in treatment recommendations if a person is acutely suicidal or in harm of immediate acute harm of harming themselves or others. We have multiple examples of stories that have been told where people were refused admission to an acute psychiatric treatment unit on the basis of disability alone. And usually the reason given is, which we hear a lot in the disability world, the reason is for safety reasons, right? But it's really interesting that many of these disability-related needs are fairly minor in terms of what safety risks they could introduce to someone. So things like an insulin pump, or there was a case of a young woman who used crutches to move around, and so they denied entry, although she wanted hospitalization for, at that point, her pretty intense suicidal thoughts and plans. So what happens often instead is that these individuals are made to stay inpatient on a medical floor. They're supervised by medical staff instead of psychiatric staff. They don't get the same benefits of group treatment or kind of the milieu atmosphere that's shown by research to be effective in these cases. And we also know the flip side. So we know that there are also people with disabilities who may experience suicidal thoughts or have a need for that type of acute treatment that an inpatient unit would not be the most appropriate for. So it's another complex issue that doesn't have one right or wrong answer, but the common thread that we try to work on is when are decisions being made related to bias around disability versus the best interest and needs of the individual in this case. So this group also has a wide spectrum that they work on, not only this question of prevention of suicide, but also just general access issues in terms of how do you find an anti-ableist therapist? What types of questions might you ask? Where might you look? Kind of to get you started on a match, hopefully a match for some important treatment for your mental health as well. So this is the fourth subcommittee group that we have. And then I mentioned that we really have five because in March we didn't expect to have this focus, obviously, like anyone. But this has been a pretty intense focus for us because it became clear in the very first couple of weeks that our country was grappling with COVID-19 that this was a spotlight on inequitable treatment of people with disabilities. So you may have followed those first few weeks and months that the crisis care standards and triage plans started rolling out from different states. And many of these were very explicit in their plans to exclude care, ration care away from people with disabilities. And they were based sometimes on diagnosis, sometimes just explicitly on disability in general. So many of those have been countered and have had to revise the standards to be more in line with laws that prohibit discrimination on the basis of disability, like the ADA. But there's still significant concern among the disability community in terms of, even with the revision of those standards, what will really happen in a hospital room without accountability and without oversight of any kind. And that's really exacerbated by the fact that the frightening prospect that there's even less opportunity for family members or caregivers or loved ones to help advocate for an individual who's very ill because of visitor bans in most hospitals related to COVID. So actually, two members of our team, along with some input from our work group as a whole, Stephanie Meredith and Janet Schaus published a blog on the AUCD Policy Talk blog, and it's linked here when you get the slides. I hope you'll read it. It really talks about how while the visitor bans in hospitals just explicitly tried to cut anyone with a patient, they failed to recognize that support individuals that are coming along with people with disabilities are much more than a visitor that, is bringing you a balloon and flowers. So they're really an integral and necessary part of the healthcare experience for someone with a disability, especially when they're extremely ill with COVID, may not be able to communicate in the ways that they typically are. So Janet and Stephanie really captured our group's feelings and then shared their own perspectives, as well as family members, to explain how this just one policy really needed to consider the needs of people with disabilities in different ways. And thankfully, we've seen positive results across our advocacy efforts. There have been several national statements encouraging these types of changes. State associations of hospitals have gone to their members, which are individual hospitals, and said, you really need some more individualized consideration within these visitor bans, and it's trickling down now to where more hospital staff are understanding policy updates so that families are once again able to be there for their loved ones or whoever they're helping to support. It can also sometimes be direct support providers that need to be there to provide care. Another way that our group has contributed more recently is we submitted comments on the framework for vaccine allocation. You may have seen there was just a 4-day quick call a few weeks ago, and we really brought up the fact that consider the equity lens as you develop a plan for vaccine allocation. And one of the comments that we put forth was not to make it diagnosis specific. Sometimes, when we see a list of like high risk diagnoses for COVID-19, we may assume that this is based on some analysis of research to determine who's really at the highest risk. But we also know the reality in policy work that certain disability groups have larger organizations, they have more power, more funding to really make their voices be heard and to get on those lists. And that doesn't necessarily mean that they are any more worthy than a rare disease that doesn't have anybody to get them on that list. So again, sometimes we have to consider equity from a within disability community perspective, and this is another example of that hierarchy where unfortunately sometimes we become pitted against each other because there's this shortage of resources. So those plans are not yet entirely clear, I guess, because there's not a vaccine to allocate, but the document that was released, we have some additional feedback on. So that's kind of the nature of our work. We have comments and then more feedback, and it's ongoing. We also wrote a statement on Michael Hickson's denial of treatment due to assumptions on his quality of life. And I want you to hear this video. It is hard to hear for me because I think it's very sad to hear this physician's assumptions about this man. He was a father of 5. So this physician you'll hear throughout the video, and it's just a blank screen because it was recorded by his wife, but it's captioned so you can read it along and you can kind of hear the dialogue between them. But we wrote a statement about this interaction because we felt that it was important to speak out about this issue in the context of COVID. And we've also published some academic pieces as well to reach that audience. And before I play the audio, I also want to just invite you, if this interests you, anything I've talked about today, but specifically our COVID group is a little more fluid in terms of we have people that join us only for the COVID work group and aren't a part of any of our other kind of moving parts. So if that sounds like you, feel free to drop us an email. So I'm now going to play for you the dialogue between Michael Hickson's wife and the physician. And I'll preface this with, if you've read about this case or if you haven't, you know that it's complicated, like so many things in life. So Mr. Hickson's guardianship was not with the state at the time. There were family issues between his sister and his wife. But what's, I think, critical to know is that he was seeking care for COVID and he had a disability. So I hope you'll listen to this with me. It's about 5 minutes.
A certain criteria, and it's not that we're afraid of side effects, it's that you have to fit a certain criteria. And right now that criteria is requiring an intubation, so if he were to get intubated, then he would be on it. But at this point, with the decision is, do we want to be extremely aggressive with his care, or do we feel like this will be futile? And the big question of futility is one that we always question. And the issue is, will this help him improve his quality of life? Will this help him improve anything? And will it ultimately change the outcome? And the thought is, the answer is no to all of those.
But what makes you say no to all of those?
Because as of right now, his quality of life, he doesn't have much of one.
What do you mean?
So
because he's so long the range, he doesn't have quality of life.
Correct.
Who gets to make that decision whether somebody's quality of life, if they have a disability,
well, it's definitely not me.
Their quality of life is not good.
So it's not me. I don't make that decision. However, it's will it affect his quality? Will it improve his quality of life? No, the answer is no.
But why wouldn't it? Being able to live isn't improving your quality of life?
There's no improvement with being intubated, with a bunch of lines and tubes in your body, and being on a ventilator for more than 2 weeks. Each of our people here have COVID, and they're in respiratory failure. They've been here for more than 2 weeks.
So they basically on
If I were to be frank, yes.
So if somebody doesn't die, are you going to think that was just
so I can count with one hand the 3 patients that have made it through.
But you can count 3.
Correct.
Okay.
Correct. Exactly. And I get your point. Like there are 3. However, he doesn't fit those 3. Those 3 are young people that don't have medical problems. This guy is young, but he has a number of medical problems.
So just so you know, my uncle is 90 years old.
Right.
He had COVID.
Right.
He has a bunch of medical problems. He has cancer.
Well, I would consider that a blessing, and every minute that he's still alive, a blessing.
Which is why to me you can't say that though, because
right.
all the directions pointed to him as being a risk that he would make it, and he did. And I just had another relative of mine pass away that was younger than him.
Well, I'm going to go with the data. I don't go with stories, because stories don't help me. Okay?
Me too.
So did those 3 that made it, did they get that dim, whatever it's called?
They did not.
No. They fought it just on their own with oxygen.
With oxygen.
And how long were they here?
Probably about 1.5 to 2 weeks, some of them even longer. So
he's been here now since Tuesday.
Right. However, his quality of life is different from theirs. They were walking, talking.
Well, he can't walk, obviously, even walk through the door to get here. So.
Right. And I don't mean to be frank or abrasive or anything, but at this point, we're going to do what we feel like is best for him along with the state, and this is what we decided.
So the fact that they're killing someone doesn't
We don't think
influence
we don't think it's killing,
Okay.
because I don't know when or if he will die, but I do think
Well, we're all gonna die at some point.
right, exactly. We all, you're right. We all are gonna die. So I don't know when or if he will die.
Well, he is gonna die one
But at this point, I don't think it would be humane or compassionate to put a breathing tube in this man and do the lines and tubes and all that stuff, because I don't think it will benefit him.
And I totally agree with you with the integration part of it. I don't want him to do it. But I also don't think that you should just sit him somewhere to be comfortable until he finally just drifts away.
Right.
That to me is futile too. Because that's saying that you're not trying to save somebody's life. You're just watching them go. The ship is sailing. I mean, that doesn't make any sense to me to not try. I don't get that part.
Right. And it's not easy. None of these things are easy. And this is a calculated decision. And we feel like this is what's going to be best for him.
Okay.
Okay?
So if this were your spouse, you would be okay with just
I would
watching?
totally do this if it was my mom, my dad, my brother, my sister, and my spouse.
That's a lie. You wouldn't.
You can call me a liar, you can do whatever you want. However, this is how I feel. I've seen this certainly more than you have. And I've seen people die.
You
certainly
said
more
more,
than
but you haven't felt it like this because it's not personal.
You don't know anything about me.
Well, and you don't know about me.
Okay, let's, I
I don't
know
want
this is
me
hard.
either.
I know this is hard, but let's,
This has been 3 years of watching it, so you don't know my life either.
Right,
When
and I'm not saying that I
watch
do. But what I'm going to tell you is that this is a decision between the medical community and the state.
And the state, and forget about his wife and his family, his
I have nothing to
his
do with
five
that.
kids.
Okay, thanks for listening. Oh, there we go. So I always feel like that after showing that, it's kind of too emotional to just move on. So if people want to share, reactions in the chat box to that audio, there were several parts that stood out to me that I can share as I see your reactions. Related to the pretty explicit statement that he believed this individual didn't have a quality of life even before acquiring COVID. You also heard kind of categorizations of people. So at one point he said that the people that he had seen progress and get better were walking, talking kind of people. So this was an example where the ableism was pretty explicit and, did have extreme results as well. So I'm seeing some other reactions coming into the chat box. Upsetting and angering. Who made him God, from a comment from Mary. That question of really deciding the end of someone's life, even though treatment was available. I think it's really important to know that this was not in a time, this was in a Texas hospital. This was not in a time where treatment, the medicine that the family was asking for, or ventilators was in any type of a shortage. So this was not denied on the basis of a shortage, or that other people who may have fared better needed this treatment, that that him taking it would have taken it for them. None of those challenges were on the table. This was just a denial of care on the basis of disability. Rebecca said that I cannot believe how verbally combative that doctor was. I agree. He definitely seemed, and of course we can presume that he also was feeling very overwhelmed and had a stressful experience with treating everyone with COVID too. But yeah, I was, she actually didn't call him a liar. She said that's a lie, which I'm a pretty stickler on that language matters. But he did become very defensive at different points. And so it is very heartbreaking. And Daniel is asking in the chat box, what was the outcome? So the outcome was very sad. He was sent to hospice, where it took a different sad turn, in that because his wife was not his next in line, she actually wasn't able to visit him and didn't even get frequent updates. So she is stating that she was told the next morning after he had passed away, like multiple hours after he died. He also, again, it's another one of those hospice related challenges. in intersection with disability is that he was not allowed food or water in hospice in the means that he already was receiving those things due to his disability. So his wife was also um, really upset about that aspect of his end of life care. So the case is complicated. To my understanding, Texas did have guardianship at this point because the family was seeking rehabilitation care for him. Um, he had a spinal cord injury, but also a stroke, and so he needed a really specific rehab program. And the family had given up guardianship to the state to get access to that program, from what I understand. So that challenged the situation. Yes, so lots of people commenting, and I don't know it with enough clarity that I feel kind of commenting on about the exact details about the hospice stay. I think that's part of the problem, is that there wasn't transparency, that his loved ones were not provided details or updates about his end of life care. And so that's a whole nother facet of this. But yeah. Kelly also adds, I also wonder if race was an issue. I definitely think that that's a concern. And the intersectionality of racism and ableism is a piece that needs, its own focus, but definitely advocates, including myself, believe that was a factor here. All right. Well, thank you for your engagement around that. I know it's a difficult thing to hear and a hard topic, but these are the types of issues that we focused on with our work group and that we'll continue to work on as they come up, because it sometimes feels like that much of the world has kind of moved on from COVID work, but for many people with disabilities, including our family who are high risk should we contract COVID, it's still very much a piece of our life and our healthcare considerations and all of that. So this work group continues. And these are 2 products that we've created, actually 3. So there's a fact sheet related to safeguards against disability discrimination that we made for the healthcare settings early in the pandemic. Then there's one that was targeted more towards individuals with disabilities and their families so they could know their rights during COVID-19. We wanted people to know you still have civil rights, and here's what they are and here's how to advocate for them. And then our partner with Kennedy Krieger did a super helpful list document that captures types of discrimination and discrimination remedies. So more from like the policy and legal side of things. So these are linked up when you get the slides, and will hopefully be on our soon to be developed website, where we'll share with you, if you're connected with HDI, they're some of our powerful partners in 2 ways, both with the prenatal work, but also the evaluation of our program. So I'm sure you'll hear about us when we have a place on the web.